so very honest. So I'm your moderator today. I'm not going to spend much time. I just wanted to give you an introduction to kind of why we chose to do a panel on this before I give the mic over to my colleagues here. So why are implants a good case study, do we think, right? First of all is the perspective of time. So it has been nearly a decade, nearly 10 years since the original volume guarantees were signed that lowered the price of implants and allowed them to be procured at greater volume and to be kind of promoted and used around the world. So we have the perspective of time, which is of course an incredible, incredible asset. But we also know that implants are a bit of a success story, right? Their procurement has absolutely just grown tenfold in the last 10 years as well, right? This is a rapidly growing method in terms of how it's being procured. And most importantly, not just the procurement, but the use, the choice for women, girls, and other individuals who want to use contraceptive implants. We know that implants are accountable for major gains in contraceptive prevalence increase in the last 10 to 20 years as well. So this is why we felt like this is a good case study to discuss with you today. But at the same time, there is an unfinished agenda. And there are probably a few more items we could have put on this agenda, but I will highlight 3 today. So one of the first items on our unfinished agenda for implant scale-up is that there continues to be low access and use of long-acting reversible contraception, particularly implants, in fragile and humanitarian settings. And we'll hear from 2 panelists about that today. Expanding access to implants through private sector outlets has also been a huge challenge. In fact, some colleagues at Shops Plus, where Sean works, they did a study they published in GHSP this summer where they looked at every single contraceptive method across 36 countries. They analyzed DHS to see what share of provision of this method is happening in the public sector and the private sector. And do you know where implants were in that ranking of public versus private contribution? They were the least likely to be provided in the private sector, even compared to IUDs, to sterilization. They were the lowest, right? So there are some major challenges we're seeing to now expanding access to implants in the private sector. And then finally, we also know on that unfinished agenda is, of course, the need to continue providing quality of care for all implant users throughout the range of services that implants require. So this is insertion, follow-up care, and really importantly, removal. And we'll hear about that today as well. So finally, before I introduce our panel, we also believe it's important to not only think today about the contraceptive implant and these very direct experiences with the implant, but to recognize that the broader context is that there are absolutely new family planning methods in our future. This is like so exciting, right? We are going to see new methods in the next decade. And so there's so much learning from the experience with a product like implants that we think will be important to improving the efficiency and the quality, and most importantly, our ability to deliver choice to those who want to use contraception. And so we're hoping the lessons today also resonate for those who may have their eyes or their mind on another product or even another service, and they're hoping to take something away. This is actually, for those, does anyone know what this one is actually on the slide? Okay, it's a microarray patch. This is a photo of the one that Georgia Tech is developing. There's a few in the pipeline. So it delivers hormone through the patch. It's different than a traditional hormonal patch. So, I mean, like, these are super exciting, right? This is actually pretty far in development. Wouldn't that be cool? Okay. All right. Well, now I'm gonna move on. So what we've done is we've actually changed the order from what you've seen in Drift Does. So I just wanted to highlight that. We're going to address those unfinished agenda points by hearing from 4 speakers who have tried to tackle these agenda items, right? And they're going to tell us about why they did that, what they've tried, what they're learning about it, maybe some perspective on what could be done differently. So we'll have 2 panelists speaking about humanitarian settings. We'll then move on to an experience about private sector expansion. And finally, we'll hear about implant removal before hopefully having a robust time for Q&A. I think I'll introduce each panelist as they're coming up. So I will hold on that for a moment. And just maybe before we go to the introductions, I'll invite you to like you're doing so many other times at this conference, grab the QR code here. We have a new package of resources available, just launched this week, about scaling up implants, lessons from a decade of implant introduction and scale up. And you'll find a lot of great materials here, including particularly much of the work Yakuba and Sean have been doing is included in this package. Okay. So with that, I will invite our first panelist to come up, and for our IT team in the back to go ahead and add the slides for the first panelist. So hopefully this will indicate that. So Megan Gallagher is the Managing Director for Monitoring, Evaluation, and Research and Learning in the Department of Global Health at Save the Children, where her technical work is focused primarily on sexual and reproductive health in both humanitarian and development settings. Megan is passionate about measurement, this is true, people say that about her, and translating research findings to learning and using data to drive programmatic change. She has an MPH from Columbia and a PhD in public health from Johns Hopkins. So welcome on up, Megan.
Hi, everyone. Can you hear me? Great. So my name is Megan Gallagher. I work at Save the Children, and I'm going to talk a little bit today about some programming that we've had at Save for the last decade and a half, looking at comprehensive sexual and reproductive health in a humanitarian response. And I'm going to focus today on implants, obviously, because that's why we're here, and talk a little bit about how they've really shifted some of the demand and our method mix in our humanitarian programming. So over half of under 5 deaths occur in crisis-prone countries. And we know that family planning could help prevent these deaths by allowing women and girls to postpone or space their pregnancies. Yet in emergencies, this is often an afterthought. So with that in mind, and with the organizational desire to prevent death for children, for women, for girls at Save the Children really focused on broadening the method mix in our humanitarian programming, notably to include long-acting reversible contraceptive methods, which includes both implants and IUDs. And what we've really found is that following the introduction of implants, demand for implants have risen, and they've increasingly become a greater proportion of the method mix. And at the same time, we've really seen the method mix expand, not just for implants, but for all methods. And this aligns very much with evidence that shows that when you introduce something new into a method mix, it brings up demand across the board. So, again, over the past decade and a half, Save the Children has applied this particular 4-pronged approach to deliver quality reproductive health services in a diversity of contexts, including humanitarian settings and fragile settings. This approach includes capacity building, assurance of supplies and infrastructure, community collaboration and mobilization, and consistent data management for ongoing monitoring, evaluation, and data use. Keeping this framework in mind, we can see the specific implant-related interventions that we've used in each of those areas. So when beginning this programming in 2012, when we were introducing implants into our contraceptive method mix in humanitarian settings, there were some things that needed to happen. In many instances, not all, but in many instances, implants were completely new in these settings. And so it was essential to train frontline healthcare providers on LARCs, so not just implants, but IUD insertion as well. And my colleague, Dr. Nancy Ibrahim, is going to talk a little bit more specifically about this because it's a bit complicated, but it certainly pays off. The other thing that sounds straightforward, but is not, especially in humanitarian contexts, is ensuring the availability of implants. And a very big area for us was making sure that implants were available in the immediate postpartum period, which is another level of training as well, and also a supply issue. So making sure that those supplies were as close to the distribution point as possible. And in acute humanitarian response, so in those initial days and weeks of a response, making sure that stock is pre-positioned. This was quite essential to making this work. The other thing, as mentioned, since people weren't familiar with implants, it was very important that at a community level, people understood what implants were. They understood side effects. They understood what an insertion process would look like. And maybe most importantly, they were able to understand how they would go about getting them inserted and how they would go about getting them withdrawn. And I think one thing that was really critical to the messaging here was that implants and IUDs were not something that people used only if they never wanted to be pregnant again. And I think there was a bit of misconception that long-acting reversible contraception was something that you needed to commit to for 5, 10 years, the rest of your life. I think that was very overwhelming. And I think, shifting that message that this could be something that you could use for a year or two, and as long as you were able to return to a health facility for removal, that it could be a very viable option. And then finally, it was essential that we monitored this. How was it working? Who was using implants? Were they young? Were they older? What were some of the challenges that we saw? And we also aggressively monitored removals and reasons for removals, because a lot of people often make the point that in humanitarian settings, people may not be able to get long-acting reversible contraception removed. And so it was really important for us to make sure that that was happening and to better understand the reasons why. Today I'm going to present just some high-level findings from a few different humanitarian settings. And so I'll be talking through some data that we've extracted from a number of countries, beginning mostly in 2012, with the exception of Syria, which began in 2017. And it's very straightforward data. I didn't do any fancy regressions. We're really just looking at what are the trends in implant use and overall contraceptive use. And I think the results will really speak for themselves in just showing that there was demand for implants as they were introduced. And so the first country that we're going to look at is Somalia. And in Somalia, implants were introduced in 2013. We at Save the Children worked in Puntland, Somalia, in 12 health facilities. And prior to this introduction of implants were not a part of the method mix at all. Oral contraceptive pills were the predominant method used in Puntland. So they were introduced in 2013. In 2014, implants comprised 10.5% of the overall contraceptive method mix. By 2020, implants were 18% of the method mix, and the overall contraceptive uptake in Somalia had increased by 223%. So Somalia is a really interesting example of just that upward trend, and you can really see implants driving that trend as a new method. In Eastern Congo, we worked in 2 health zones, Masisi and Mweso, in 28 health facilities. And this DRC example is a little bit different than Somalia in that implants were already a part of the method mix and they were highly demanded. They'd been introduced a few years prior and people were very excited about them. They were talking about them. They were coming to the health facilities and asking specifically for implants because they knew they were there. But over the course of this 8-year period that you're looking at now, implants averaged over 50% of the method mix. And as you can see, demand for implants and other methods increased with time. I'm realizing that as a researcher, I neglected to do something very important, which was orient you to these charts. So I should note, since we've got a few more countries to go, that if you look at this chart, the line that you see is the percentage of implant use over time. The darker maroon color is the number of implant users and the number of new implant users. And the orange color is the total new users of contraception. So these are our findings from Yemen. So in Yemen, implants were also introduced in 2013 and constituted 5% of the method mix. And by 2020, implants comprised 15% of the method mix, and the overall contraceptive uptake had increased by 442%. And I think, you can see in this particular graph, if you look at the period in early 2018, you can see implants had kind of risen. They're the little ones at the bottom. And then they fell. And I think this particular scenario really highlights a challenge that we do have in humanitarian settings and everywhere really, which is stockouts. Implants were highly demanded, people were very excited about them, and then we had a really hard time getting them into the country. And it was a really good lesson learned for us, and a lesson learned just in how to get things where they need to be, which is always a challenge in humanitarian settings. I'm not going to say that we have found the solution, but I think it was really important for us to see that the demand was there, and as much as we are able to predict what that demand will be in the future. And then finally, I'm going to present some data on Syria. And Syria is a little bit different than some of the other countries as well. So our support to Syria began a little later in 2016, 2017. And at that time, the contraceptive method mix was heavily skewed towards oral contraceptive pills and IUDs. And implants weren't a part of the method mix, and they were not known to Syrians. They're very new. And implants were introduced, but first extensive training had to be done with providers. And in Syria, we have a model where given security, we work through a partner organization, Syria Relief. And so Nancy will talk more specifically about how that training was done in a context where Save the Children was not able to directly provide that training or technical assistance. But you can see here that even though the numbers are quite small, implants became a part of the method mix, and I think we're interested to see where that might lead in the future. And so just a few points I want to highlight, kind of keeping in mind that four-prong approach. Existing method mix really should be taken into account when introducing implants, and I think that's going to look different in different places. And so knowing what people are familiar with and then tailoring that training, that supply, and that monitoring is very important. Trends over time are not linear. We see ebbs and flows. There are times where there are stockouts. There are times where people might not be able to access facilities or information in a timely manner. So we should not expect a linear trend, and we should not see linear trends as success or failure. And then finally, introducing new methods to the overall method mix really does drive demand and uptake for that method, in this case implants, but also more broadly. And then just to conclude, and really kind of thinking about this in the humanitarian framework, in communities that are impacted by crisis, there is and continues to be a strong demand for family planning, including LARCs and including implants. When implants are thoughtfully introduced, they're well received and contribute notably to an overall method mix in humanitarian settings. And finally, we really found that this program implementation model, though simple, has been really effective at expanding access to implants and contraception more broadly in these 4 humanitarian settings, as well as many other humanitarian settings where we work. Thank you very much.
I always just find it so impressive and humbling to see what people can do in the settings we often kind of write off as being impossible, right? And so I really appreciate you showing us that this is working, and you're expanding method choice. And I'm super excited because now you're going to dive a bit deeper into how that experience looked. I'm going to invite up our colleague Nancy Ibrahim, who is a senior advisor for reproductive health at Save the Children USA. She's based in Cairo. She provides technical support for maternal, newborn, and reproductive health programs and contributes to building the capacity of health staff and partners through delivering technical training for service providers across Egypt, Syria, Somalia, Lebanon, and Niger. She enjoys developing and testing new and innovative capacity building approaches. And Nancy is a medical doctor by training and holds a clinical doctorate degree in family medicine and primary health care, and is a member of the Royal College of General Practitioners. Superstar over here. So thank you, Nancy. Come on over.
Thank you, Megan. Hi, everyone. I have to thank Megan for paving the way for my presentations. She almost mentioned everything. So as we talk today, we will talk about a little bit some of the details of how we introduced implants in northwest Syria. So as you know, the war started in Syria in 2011. It still remains one of the most challenging and complex humanitarian emergencies in the world. Displacement coupled with the violence, socioeconomic crisis severely impacted the health system. Our program started since 2017, and from that time till now, around 217 facilities got attacked. During our project lifetime, our facilities were attacked 3 times. Twice, we had to even move to another facilities since the damage was significant. So this led to a significant barriers addressing the family planning needs for refugees in several locations in northwest Syria. And as we started our program, most of the facilities weren't really equipped to provide such services. So our program work in northwest Syria, in Idlib and Aleppo. We support 7 health facilities, 5 primary healthcare units, and 2 maternity hospitals. We work in partnership with our partner Syria Relief. Our offices by the borders in Gaziantep, and then they operate inside Syria delivering services. As Megan was mentioning, our project had main objective of delivering quality family planning and post-abortion care services. So we did that through building the capacity of the service providers, community mobilization and outreach. We had a team of trained community health workers who did the community awareness activities. We did provision of family planning supplies and commodities, and a very strong monitoring and evaluation and robust system of supervision as well. So as we started the program, the method mix was mainly consisting of ID and oral contraceptive pills with some use of condoms and injectables. Implants weren't known or available at northwest Syria. So we started introducing implants to our method mix, which wasn't an easy task. We started with the provision of Jadal and Implanon next at the supported health facilities. We trained our service providers on implant insertion and removal, and we established supportive supervision tools for the supervisors. Training wasn't an easy task for us. It was really challenging to do the capacity building trainings for service providers, mainly doctors and midwives in northwest Syria. We have tried multiple times to get approvals and cross-border checks, but we failed. Starting from 2017, we were trying, and until the beginning of 2018, we really didn't succeed in getting the approvals. So we had to think of other innovative approaches that we can do that. And in 2018, the concept of remote training wasn't really popular. It was something that we wanted to try because we failed to get face-to-face trainings at that point. So we had our supervisor on ground to be a co-facilitator with us, with a remote trainer by video, by Skype video training. And actually, it worked very well. We weren't sure that they will grasp everything through the remote training. It was a very new concept for the service providers in Syria. But it really worked. One of the most important things also that we worked on was the counseling. It's a very new method for everyone, for the service provider, for the clients. So we really dedicated a lot of time delivering these packages about counseling, especially side effects and how to manage it, and addressing rumors and answer all the questions from the clients to ensure that they properly understand how implants work, how to insert it, how to remove it. Procurement, and this was also one of the biggest challenges for us. So as I mentioned, implants weren't available locally. We had to procure it internationally, which with the supply chain issues took longer than we expected. We tried to reach out to UNFPA, but they were providing methods, but not implant, because it's not widely known in Northwest Syria. No other facilities are providing it, so they didn't feel like there is a demand to procure this method for Northwest Syria. We also established and developed IEC materials for implants in specific. We have reviewed it, printed, tried to contain all direct, simple messages for the clients, and we also distributed it to the reproductive health working group. So not only to be distributed in our facilities, but we felt like clients should know that there is another method, even if it's not available in all the facilities, but it's something that we saw that it would be like introducing the method with the community and with other partners as well. As I mentioned, we developed the supportive supervision tools, which was translated in Arabic for the service providers and supervisors. It was also used in our competency-based clinical trainings as a tool to ensure that the service provider can follow every step and also to assess and plan a follow-up plan after that. So as I mentioned, it wasn't an easy trip for us. Supply chain and stock outs happened throughout the lifetime of the project and had delayed our uptake of implants. Service provider training was something that is very, very challenging because of the issues of crossing the service providers, the borders with Turkey. One of the challenges as well was the community hesitancy to use the implants. It was a new method. There was a lot of misconception and rumors around implants, and we had to work around all these challenges to ensure that we are providing services. So one of the things that we have done to address misconception was our community outreach activities. We had a team of trained community health workers who conduct household visits and also community awareness sessions. They were providing information about all the methods, in particularly implant. They also addressed rumor and misconceptions. They referred the clients to receive services. They also were following up with the clients, especially for side effects and those who are dropping out. And this was particularly important and really challenging because Syria doesn't have a specific address system. So, and people are on the move all the time. So it was really challenging to track some of the clients. But by the end of the project, I think our total reach was around 65% of those dropouts, which was really a good percent. So as I mentioned, throughout the lifetime of the project, we have delivered competency-based clinical trainings. We have delivered counseling trainings for service providers and for the supervisors as well. We have tried to engage with other local partners to also transfer this knowledge and ensure that Syria has qualified trainers for implants. So as we were wrapping up the project, we really felt that we need to transfer this knowledge to other partners and present our experience with implant introduction to the method mix. And in these efforts, we coordinated with the Reproductive Health Working Group a TOT for trainers on implant specifically and other methods as well. And one of the criteria for the trainers to be selected for this training was to be based inside Syria, because we have a lot of trainers in Gaziantep and in Turkey, but there is always the challenge of moving across borders. So we have trained 10 trainers on implant and other methods. And as we did this, we presented that to the Reproductive Health Working Group as well as UNFPA to start procuring implants for other partners. They agreed to do that for partners who have qualified trainers throughout the training. So this was one of the successes as we were wrapping up the project to ensure that this work will continue. So these are one of the results from the program. So you can see these are the tracking of all the new users for family planning methods throughout the lifetime of the project. So one of the biggest methods that has been used is oral contraceptive pills, followed by ID, and then injectable, and after that, implant. This is the number of new users for implant in a specific, and as you can see, in 2017 till 2018, the uptake was really slow, and it was because the lack of trained service provider as well as the low supply of implants that we had at that time. And once we got the supply and did the training in 2018, you can see the increase of the uptake throughout 2019 and 2020. And actually, one of the things that really helped us was monitoring and following up of the side effects. Because it was such a new method, there was a lot of rumors around causing infertility and causing a lot of other health issues. So we were really focusing on ensuring that the counseling on the side effects happens from the start, and also ensuring that all the service providers have the technical capacity to insert the implant. As some of you might know, JIDAL is a little bit tricky. It's consisting of 2 rods. It requires a little bit of experience in doing it. Implanon next on the other side, it's easier to insert. So we were trying to working, especially some of the midwives had some challenging in insertion of JIDAL, with on-job training, with the coaching, and maybe trying to start with Implanon next, and then make them insert JIDAL. So we have seen a very good uptake within the community. We have seen women coming asking about implants, which was something we didn't expect that early in the program. But unfortunately, with the COVID and the supply chain disruption, we didn't manage to get more supply in 2020, which led to a decrease in the uptake. This decrease wasn't because clients weren't really were reluctant to use implant. It was very much related to our supply. So some of the facilities that we were supporting doesn't have any implants, despite that women were coming to the facilities asking for implants. So as we were wrapping this project, we had an evidence that implant can be introduced in the method mix in Northwest Syria. Women are actually really interested in using it. Some of them really refer it even to the ID, which was really remarkable in some of the focus group discussions that we did. So we presented all this work to the Reproductive Health Working Group. We really advocated for other partners to adopt this and try to introduce the implant in their method mix. And as I mentioned, in the end, we agreed with UNFPA that if we have qualified trainers on implant inside Syria, they will be able to procure that. So by 2022, we concluded the training for 10 trainers who are well known for the Reproductive Health Working Group. So anyone or any other organization that really wants to conduct this training can use those trainers. And hopefully soon we will see more facilities that are using implant in their method mix. I think that's all from my side. So thank you so much.
Thank you so much for that, Nancy. It's a great example of expanding method choice. And so next we're going to move from humanitarian settings and that unfinished agenda item onto the private sector. And so for that we have private sector extraordinaire, Sean Callahan. Sean is a senior project manager with Apt Associates with a ton of experience leading and implementing projects designed to help USAID missions and their partners better understand and capitalize on opportunities to better engage and leverage the private sector in both HIV and family planning efforts. He was a private sector advisor on the Shops Plus project, and in that role he supported specific efforts in the Caribbean and East and Southern Africa, including the Shops Plus Tanzania Field Support Program, which is what you'll hear about today. And he holds a Master of Public Policy from the University of Virginia. So come on up, Sean. It's coming right up.
It's showing up on here. There we go. Okay. Oh. There we go. Okay, thank you. Thank you so much for having me here today. My name is Sean Callahan. I'm a private sector advisor with Apt Associates here on behalf of my colleague, Maureen Ogata and Dakana, to present some work we implemented in Tanzania to expand access to implants through private health facilities. Great. This effort was part of our work under the Global Sustaining Health Outcomes through the Private Sector, or SHOPS Plus project. SHOPS Plus was USAID's flagship global initiative in private sector health, working to harness the potential of the private sector and catalyze public-private engagement to improve health outcomes. Led by Apt Associates, the project worked in over 30 countries over the past 7 years across multiple health areas, including family planning, HIV and AIDS, child's health, tuberculosis, and more. Our support focused on improving the enabling environment for the private health sector and increasing effective public-private engagement, strengthening private provision of health information products and services, and sharing innovative, emerging, and tested private sector models. To set the scene for this presentation, Megan already previewed it a little bit, but it's important to recognize the role that the private sector plays in the provision of modern contraceptive methods. A secondary analysis of 36 countries' DHS data conducted by some of my SHOPS Plus colleagues indicated that across these countries, 1 in 3 modern method users access their method from a private source. This role varied substantially by method type, with private sector playing a larger role in short-acting methods. The data also highlight a potential gap in the private sector, though. As Megan mentioned, even compared to other long-acting and reversible methods, where its role is already more limited than short-acting methods, private sector delivers a very small proportion of implants. Looking specifically at Tanzania, we see a similar pattern. In this graph, we see the overall number of women using each method in the dark green bar. In the inner light bar, we can see the number who access that method from a private sector source, with the private sector share noted in the percentage. From this graph, we can see that Tanzania's private health sector plays a substantial role in the provision of short-acting methods, ranging from 1/3 of injectables to over 80% of condoms. Oop, not yet. Sorry. Its role in the implant market is much more limited, serving just 11% of users. As implants are the second most prevalent method in Tanzania and increasing at a faster rate than any other method, this limited role has important implications. First, it puts the burden for absorbing the growth squarely on the public sector. And second, it has the potential to limit access to one of the most popular methods for women who would prefer a private sector source. So through this activity, SHOPS Plus set out to answer 3 questions. How can access to implants through the private sector be improved in Tanzania? What are the current approaches for capacitating private providers to deliver implant insertions and removals? And are those approaches effective and sustainable? And given the limited private market, can private supply chains for implants be strengthened? At the start of our work, we conducted a rapid assessment to identify opportunities and barriers to private sector implant provision. The assessment identified three main challenges that private providers faced: access to and structure of training opportunities, access to affordable commodities, and pricing pressures that created challenges for sustainable service delivery models. For the first two, it's important to note that these were primarily felt among independent for-profit providers, as donors and government under the Implant Access Program focused mainly on public facilities. And within the private sector, donor-supported social franchises were a main avenue for both trainings and commodity access for implants. Private providers who were not a part of those networks, though, had limited options. When space was available in public trainings, they might be able to participate, but access was not a guarantee and generally very limited. Commodity access was a bigger challenge. While donated or donor-subsidized commodities had traditionally been available through social franchises like Marie Stopes Tanzania and PSI's Tunza franchise, changes in the funding landscape in 2019 had caused these providers to shift toward a new partnership model in which they accessed implant commodities from the government supply chain. In addition, implant products that were available through the Implant Access Program, namely Jadel and Implanon, were not available in commercial supply chains, which severely restricted non-franchise providers' ability to access these deliver the method. Pricing pressure was the final challenge. Because of the emphasis on public sector channels, implant insertion and removal were typically available for free in Tanzania. Even within the private sector, the use of donated commodities helped to bring down prices below commercially sustainable levels. While these strategies successfully helped build demand and increase access, they also created a normative expectation that private providers should provide implant insertion for free. This expectation undercut the emergence of a sustainable, purely private model, since private providers wouldn't be able to cover their costs without access to these same subsidies. Tanzania's strong history of public-private partnerships in the health system provided an opportunity to address many of these gaps. In the country's decentralized health system, district-level officials deploy formalized contracts with private providers known as service-level agreements to increase access to priority services. Historically, these agreements had been used to engage faith-based hospitals as district-designated hospitals or to mobilize private sector participation in vaccination campaigns or HIV service delivery. In 2019, many of the social franchises began shifting to this contracting model to continue supporting their implant provision. Under these contracts, private facilities can access free commodities, technical support, and even staff from the public sector. In exchange, they must comply with quality of care standards and negotiated service fees, submit to supervisory visits, and regularly report service delivery data. For our activity, we leveraged this contractual framework to address challenges that the non-franchise providers faced in delivering implants. We partnered with the Private Nurse Midwives Association of Tanzania, or PRINMAT, and the Evangelical Lutheran Church in Tanzania to mobilize 39 private providers in Arusha and Dodoma to participate in a pilot effort. Working with the reproductive and child health section of the Ministry of Health and district officials, we organized private sector specific trainings to capacitate these providers on implant insertion and removal. At the ministry's guidance, these trainings had to cover the full range of family planning methods, even if providers were already delivering other methods. And they included a practicum at public facilities and follow-up supportive supervision visits at each trained provider's facility in order to fully certify them to deliver implants. We originally set out to support a commercial product and distribution model. However, at the time, there was only one implant available from a private distributor, which was Leviplant through DKT Tanzania, and this had only just been registered. Instead, private providers were given the option to use the SLA model, in which they were able to access commodities via an intermediary public facility. Our providers opted for this second option, motivated by the desire to access Implanon which was the product that was in highest demand in Tanzania. Because SLAs operate at the district level, there is some flexibility in how they are applied. As a result, district authorities offering differing pricing guidance to our trained providers, which in turn led to a wide range in prices, from $1.50 to $6.45 for insertion and $2.15 to $4.30 for removal. It's unclear from our follow-up with the providers how they determined these exact final prices and if they covered the full non-commodity costs of insertions and removals. We did note, though, that these prices weren't set in stone, and the providers reported that they would reduce prices on their own for clients without an ability to pay, so that financial barriers would not prevent access. In total, these 39 providers delivered almost 1,400 insertions and 359 removals over the 6-month pilot period. These two graphs show insertions by month on the left and removals by month on the right. The dark blue bar is for our providers in Dodoma, and the lighter blue bar is for the providers in Arusha. As you can see from the data, even after the initial rush, demand for insertions remained relatively high and consistent throughout implementation. After the pilot period, because of the nature of the contractual relationship that we helped to establish, these facilities were able to continue offering implant insertions and removals on an ongoing basis. While a few had to stop eventually due to staff turnover, 32 of the 39 were still delivering the method at the end of the project over a year later. The experiences highlighted lessons for future private sector models. First, stakeholders should consider how private providers can be trained more efficiently. As noted, the Ministry of Health required that trainings cover all family planning methods, even when providers were already delivering most short-acting methods. This requirement meant that the trainings lasted 2 weeks, during which providers were away from their facilities, and would represent an important barrier to scaling the model, both because of the costs required to implement these trainings and because providers simply can't be away from their businesses for that long. Second, the limited private supply chains for implants requires both global and local solutions. Access to products covered under the implant access programs is still cost prohibitive even after the program ended, which limits viable options for private markets and needs to be considered through future market shaping efforts. One local solution to consider includes pairing efforts to capacitate private providers with efforts to increase targeting of free implants as part of a total market approach. This can help to create more market space for private sector brands, addressing some of the pricing challenges that private providers face and opening the door to more commercially oriented, sustainable private sector models. This ability to charge a realistic price is likely to be key to sustainability and viability of these markets, and so strong consideration needs to be paid both to how to bring costs down and how to incorporate financing solutions like the inclusion of implant insertion removal into health insurance packages. Just a quick note on some of the post-pilot updates in this field. So since we ended our program, we recognize that many of the solutions require longer-term involvement and changes that the governments need to embed into policy frameworks. But in the meantime, we've seen some quicker interim steps being taken to continue and to scale this work. So for example, DKT has partnered with UNFPA to continue increasing access to for private providers to trainings. As part of this effort, they're delivering an implant-specific training program that, while it doesn't lead to full certification as a family planning provider, does allow private providers to begin offering implants. In addition, while still drawing on donor support, the model is beginning to build out a private distribution channel for the product that can be built on and expanded as the market matures and grows. I think I'm out of time now, but I look forward to your questions. And in the meantime, you can read more about our work in these two briefs. I meant to bring copies of them, but I forgot them at our booth. So you can stop by and pick some up there, or you can go to our website. And thank you for your time, and I look forward to your questions.
Okay. Excellent. Thanks so much, Sean. It's really impressive work that you've been doing there, and I think a lot of us have been referring to this case study of what what you all have worked on in Tanzania is a great example of how to explore the opportunities for expanding implants in the private sector. So fourth and final, but certainly not least, is Yakuba Adragu. Yakuba will be presenting about implant removal. So now again, we're shifting focus to another unfinished agenda item. Yakuba is a colleague of mine, so I will speak very favorably about him, more so than anyone. But Yakuba is a public health specialist who has over 15 years of experience in project management, monitoring, and evaluation. He has a master's degree in public health, a university degree in statistics and epidemiology, and has a postgraduate diploma in nursing, so he's multifaceted. He currently works for JPIGO. He works on the Performance Monitoring for Action project and also supports our USAID Integrated Health Services project as a technical advisor for health system strengthening and quality improvement. And prior to doing that, he worked very closely as our program manager for the Expanding Family Planning Choices project in Burkina Faso. So Yakuba, I welcome you up and I look forward to your presentation.
Thank you, Megan, and good morning, everyone. Thank you for this opportunity offered to me to share this experience from Burkina Faso about understanding and addressing barriers to implant removal services. Burkina Faso, for those who don't know, is this country in West Africa with a predominantly young population. Almost the half of the population is under 15. And for the indicators related to family planning and reproductive health, the levels remain critical. The total fertility rate remain high at 5.4 children per woman. We still have more than 16% of women having unmet need for family planning, and also the mortality, the maternal mortality ratio and the neonatal mortality rate remains high. Particularly for family planning, we can say that some progress have been made during the last years, and as you can see on this graph, the prevalence contraceptive rate rose from 18% in 2014 to 31% in 2022. And in the graph on the right side, you can see that the implants are the most common method used by women in union in Burkina. This is a very good thing, but it's also critical because in such situation, the health system should be able to provide comprehensive health services, including implant removal to clients. And what was the situation when we were starting this project? In 2017, the performance monitoring for action data were already pointing out that around 7% of the women were seeking for implant removal were not able to find these services in Burkina. And we needed to understand more about the reason associated with this situation. That's why the implementation of Expanding FP Choices project was timely, and this project aims to provide additional evidence on the current state of implant removal service delivery in Burkina, and also to implement pilot interventions for implant removal services to identify and promote best practices. So to achieve this, we decided to conduct a desk review and a landscape assessment in very close collaboration with the Ministry of Health, particularly the Directorate of Family Health in 2018. And we used these data to mobilize all the stakeholders to discuss, and we decided together to implement a roadmap to address the gaps. In terms of methodology, the landscape assessment was based on the 8 implant removal standards proposed by Implant Removal Task Force. And in Burkina, we decided to focus on 4 of these 8 standards where the rapid desk review didn't find enough information. So for the assessment, we used 2 checklists, one at the primary health facility level to assess the skills of providers about standard implant removal, and we used another checklist for referral health facilities to assess the skills of providers about deeply inserted implant removal. And in terms of coverage, 3 regions were concerned by this study, and in its this region were selected based on the number of implants inserted during the year of 2017. And in each region, we selected the 2 districts having the highest number of implants inserted, and so on for the health facilities. We interviewed managers and decision makers at all the levels of health system in Burkina. What was the key result of this study? We wanted to identify the gaps and barriers to quality implant removal service delivery. And for that, we wanted to know first the level of confidence of providers about implant insertion and removal. And as you can see on the graph, more than 70% of the providers stated they are confident or very confident about implant removal and insertion. But when it came to use the standard checklist to assess the skills, you can notice in the graph at the right side that only 17% of the providers were able to perform a quality implant removal, meaning to meet, to complete all the items on the checklist in the correct order, 80% of these items. And we know that we use it 80%, but in many situations, the required level of competency is 100%. We also wanted to know if the providers have already been in a situation having a client in front of them seeking for implant removal and didn't get it. And 37% of the providers said that they have already been in such situation. And the reason they give by providers for not meeting the client request for removal was first the lack of adequate equipment and material for implant removal for 44% of the providers. 25% of providers advised the client against the removal, saying that they estimate it is not timely. And another 25% attempted to remove the implant but couldn't succeed. Another barrier we identified was related to the cost related to the service delivery. While the Ministry of Health is implementing a free of charge policy for family planning, we noticed that providers are still charging fees to the clients, and the reason they give for that is that they are sometimes lacking supplies and products. The Ministry of Health is supposed to give them this product and supply to allow them to apply the free of charge policy, but sometimes they are lacking those items, so they are obliged to charge fees. And those fees are sometimes out of the affordability of clients. So the second objective of this project was to implement pilot interventions to identify some best practices and to promote them. So with the other stakeholders and the Ministry of Health, we decided to implement the roadmap, and that resulted in the provision of materials and equipment to some health facilities, developing and validating training materials, integrating implant removal data into the HMIS, and training a pool of trainers on deeply inserted implant removal using ultrasound. In terms of conclusion and policy implications, we can say that this project was a great opportunity for the stakeholders in Burkina to know better about it and to understand the issues facing the quality of implant removal service in Burkina. And we also noticed that some gaps need to be filled in terms of insufficient of material and equipment necessary for quality service delivery, the cost associated to service delivery, and the discontinuation of those services, limiting the access, and also implant data were not collected systematically, and the providers were lacking skills for implant removal. So using this information, more attention was subsequently focused on the implant removal in the current National Family Planning Plan running for 2021 to 2025. And this lesson learned also helped to integrate implant removal aspects in new project by many stakeholders in Burkina. Thank you for your attention.
Thank you, Yakuba. Trying to be impartial. I think it's really incredible, right? By the end of the program, they were changing the way removal was considered in the entire National Family Planning Plan. So what we'll do now, we actually have 14 minutes for discussion and question and answer. So I'll invite the panelists, if you wouldn't mind just joining on stage. I had them sit here so that they could watch one another's presentation. It's very hard to do that from up front otherwise. So we'll take a seat, and Yakuba, if you could go up too. And I will also jump up there as well. There's microphones in the middle. Okay. So what we'll do is invite folks to come up to one of these microphones that are in the corridor thing, and ask your question there. When you ask your question, please keep it brief if you can, and also do introduce yourself. We'd love to hear who you are. And before, actually, I know we already have a question that's ready, but maybe I'll get them started on one as their minds are churning. So each of you covered one of our unfinished agenda items for implants. And many folks here are thinking about implants, but also other methods. And so I'm curious, as you take this perspective of humanitarian and fragile settings, or the private sector, or quality of care and removal, what advice might you provide to others who are in a place where they're maybe in an earlier stage of introducing a contraceptive method, and there's something you hope that they're thinking about or considering that will be important to the success of that product for expanding method choice? Maybe I'll start with our humanitarian crew over on this side of the room.
I feel like, I don't know if this is working. I can just speak loudly. It's working, great. This is probably an unsophisticated answer, but I think just try it. I think sometimes as we let a lot of our resistance or our reluctance, this might not work in a humanitarian setting. This might not work in a place where people might be opposed to it. And I think sometimes we just need to try, and we aggressively monitor, and we learn from that. And so that would be my piece of advice.
Excellent advice, Megan. Yes, I totally agree. Sometimes we stick to some perceptions that we cannot do this, especially in humanitarian settings. But one advice would be plan ahead. Try to see what others learned, what challenges. But definitely try it, because it's really rewarding at the end, and definitely a lot of work can be done in humanitarian setting.
Thank you.
Thanks. I would say just don't forget about the private sector. Obviously there needs to be constraints on when you're introducing a new project, because you can't introduce it everywhere all at once. So it's just not, there are resource constraints. But you just be from the beginning thinking about what your strategy is for engaging them, what their envisioned role would be in the model, so that from the beginning your strategy is reflecting kind of their needs and the incentives that they face, and you're not trying to fix the situation afterwards, but just being kind of upfront from the beginning.
Thank you. I think that expanding choices for FP client is very important. One advice I can say is that if to consider if this method, this new method, require client for the client when he need to stop using the method, if this require provider assistance, it should be clearly explained to the client before he start using the method, and this service should also be taken as a priority for the health system as well as providing these services. I think this will be important, because if provider are not if the client are not satisfied, it's a potential source for many other clients to be demotivated and not use the method. Thank you.
Yeah, thanks for that, Yakuba. And one of the themes I heard, I think, from everyone was this idea that these are exactly the items to plan ahead for, right? To plan ahead and in some ways to think about, what are we going to measure? I think to Megan's point about let's just try it. We don't know if it'll work, but if we have good data and we know what we're hoping to learn, then we can quickly assess whether or not it's working. And then a lot about, just plan ahead. Think about removal if there's a reversibility challenge to the method, and also think about the private sector. So with that, I'll turn it over to the audience to see if you have some questions for us. And also please let us know to whom the question is directed. So I'll start with Sunita. If you could maybe jump up to the microphone, that would be helpful. And let us know to whom you're asking.
So thank you very much for wonderful presentations, wonderful presenters. My name is Sunita Singhal, and I work for JPIGO. So my first question goes out to Nancy. Regarding your presentation, I noticed that you procured Jadel as well as Implanon Next, 1 rod and 2 rod. So how did you give a choice, or what criteria did you use to offer 1 rod or 2 rod to a particular client? That's one question. So should I put up my second question right now, or wait for?
Yeah, go ahead.
Yeah, so my second question is to you, and this is regarding difficult removal. That's a very important quality issue, and currently I'm very much concerned about this. So if you could tell me, in the training package, when you train about the insertions and about removals, how much emphasis is given to the difficult removal? Do you think the providers need an extra training for those difficult removals? Is it included in the training package? Do you identify few select providers while you are training them so that they can be designated as experts in difficult removals? Do you also need to identify specific centers where this can be done? So if you could throw some light out of your great experience. So over to you. Yeah. Thank you.
Thank you so much for your question. So at the start of the program, we actually tend to make the providers provide what they feel comfortable with, especially midwife, were sometimes reluctant to provide Jadal because it requires a little bit of skills. So at that point, we were providing Implanon with some of the facilities that doesn't have like a doctor, with the midwives. And as they progressed and they are skilled, we left the choice for them and for the client, definitely, because some of the clients were really reluctant about having 2 roads, despite of explaining how the process is. Mm-hmm. So if they feel comfortable with just having 1 road, we did that.
Thank you. Thank you.
Okay. For the training, when we are providing trainings for implant insertion, effectively we include implant removal. It's part of the training for implant insertion. Most of the time, they don't need extra training for implant removal. But for deeply inserted implant removal, sometimes during the training we do not have enough client to practice. They practice on anatomical models, but most of the time they didn't get real client to practice. Mm-hmm. And when it came to do the deeply inserted implant removal, sometimes they can face some challenges. That's why sometimes we need to do some extra training. But for standard implant removal, we are not doing some extra training. Yes.
So what percentage of removals have been difficult?
Okay, for that, we don't have numbers, but in our country, as you see the number growing, this is sometimes due to campaigns. Sometimes some stakeholders are conducting some campaign outreach for implant insertion, and sometimes some providers are some difficulties to do even the insertion. So we can have a lot of implant deeply inserted when it is conducted in such a way. So that's why when you can see that PMA data show that 7% tried to have the implant removed, but they couldn't have it. Sometimes the women are going from health facility to health facility. Sometimes they go up to 4 to 5 health facilities to get the implant removal with a large injury on the arm, and sometimes it's not easy.
Yeah, and I know there's another question, so maybe as we're switching kind of questionnaires, just to note, I think a couple things. The measurement of difficult removal is incredibly challenging because there are so many permutations of difficulty, right? Sometimes it's about the provider's skill or whether they have the materials, and I think you saw that in Yakuba's data. Sometimes the implant truly is non-palpable. It's actually, you can't find it and have to go as far as using an ultrasound to locate the implant. Those cases we know are very rare, and those we would recommend only be kind of trained into a subspecialty group who'd be capable of doing a surgical removal. But there are there's these medium difficulty. And I think maybe even just to say, so that is abundantly clear, the way to prevent a difficult removal is through quality insertion, which starts with competent providers who are, trained well and know how to do the procedure. And so, there's a lot of ways to tackle that problem, and we're trying to still wrap our heads around that. But you'll find some of the resources for that at the link I shared earlier. I think we had another question back here first. So let me go here because that was the hand I saw. Oh, okay, thank you. So we're going to go over here. Yes. Can you come up to a microphone just to make sure we can hear you and introduce yourself and let us know who the question is to?
Good morning, everyone. My name is Melvin. I am a reproductive health and policy expert, having close to 17 years of work experience as a nurse midwife. And I just felt horrible when I heard him say, someone will walk to 5 facilities trying to get the implant removed. Because usually it's the simplest procedure you want to do. The insertion is usually good when it's really just subcutaneous, not deeply inserted. And normally the removal is the simplest procedure I love doing. But one thing I wanted to point out is just from your presentation, I noted that the reduction, or rather the drop in uptake, and I also wanted to associate this with the policies at the time. You remember this, I'm looking at the years, and it's the time when we had the global gag rule in place, and I know there was a real reduction in funding to UNFPA, something that also impacted hugely on the distribution of contraceptive commodities entirely across the world. Yeah. And so I just wanted to relate that to the policies in place. Yeah. Thank you.
Excellent point. Yeah, that's a good point. Thank you. Yeah, go ahead. Yeah, certainly implants in all of their volume are not impervious to the political challenges that contraceptive commodities face in their financing. So thank you.
Okay, first of all, thank you very much for the great overview. My name is Angela Barr. I'm working with DSW in Germany, and I'm not an expert on implants. Okay. Therefore, I have a question. Yeah. I have seen the studies, and my question is really if they have been age differentiated also, and what about the situation of young women and nulliparous women? So I'm quietly interested in what are your experiences and knowledge about that. Thank you.
I can comment on this.
That's a great question. We do disaggregate our data by age. So we look at 10 to 14, 15 to 19, and 20 to 24. And to be honest, I didn't present it, but a lot of it really kind of depends on the existing method mix. I would say in places like Eastern Congo, where implants were highly demanded, they were also highly demanded among younger people as well. And I think so much of that goes back to the counseling. I think if implants are put forward as something that is something that you need to use for 3 to 5 to 10 years, then there's a reluctance for younger people. But I think, we really, in our counseling model, made sure that people knew that they could use implants for shorter periods of time. But it was easier. We saw in our younger populations much more uptake when implants were popular. And then as implants became popular in some of those method mixes, we saw the age follow that as well. Great question.
Yeah, and we do have to close, unfortunately. So I'll just say, what we know from sort of the global data on implant use is that well, implants are certainly very safe for adolescents, and the WHO endorses that. We do see them used by younger populations, though perhaps one of the distinctions is primarily those who have had at least one birth. So, and of course, they can be used safely by nulliparous women, those who've had no births, but we see that it tends to be used mostly among those who've had at least one child, which I think tracks with a lot of what we know about cultural norms around kind of proof of fertility before using a hormonal method. So with that, thank you so much for joining us today, and I wish you a good conference proceeding going forward. Thank you. Thanks, guys. Can we take a group picture? Mida, will you take our picture? Since I see you right there, I'm like...